that's troublesome, right? Because we as we talked before, we don't know what we're doing for cardiac arrest, but oftentimes I think we give NarCAN because, well, what else are we going to do? Hey everybody, welcome back to the Monday Afternoon Journal Club. Ed Bowder and Dan Schwester, and today we are talking about a study that came out of our backyard in New Jersey. If you follow the show, if you follow the Journal Club, you know we talk a lot about cardiac arrest, and this is another study, Danny, where we have no idea what we're doing.
Every time, Ed, I think every time I think it's like, okay, he's done with this, we're not going any further. You just find
no. Listen, it's an important hill to die. So we're actually going to be talking about two studies this week and next week because they kind of contradict each other, and they came out within a month of each other, which was the kind of fascinating thing. So this is coming from the Journal of Emergency Medicine, outcomes of out-of-hospital cardiac arrest patients who received naloxone in an EMS system with a high prevalence of opiate overdose. This was done with some doctors from Camden and from Philadelphia, which again is our neck of the woods. What they looked at here was they looked at patients who had opiates in their system when they went into cardiac arrest, and whether or not receiving NarCAN was associated with improving survivability. Really quick numbers here. The consecutive sample was 769 out-of-hospital cardiac arrest patients, 175, that's 23%, received naloxone. There was no difference in ROSCs for survival to discharge or modified Rankin scores. And again, Rankin scores it's a number that talks about neurologic outcome in cardiac arrest. So basically, out-of-hospital cardiac arrest patients who received NarCAN, despite being younger and having fewer comorbidities, which is important, they had similar outcomes compared to those who received usual care. The difference in baseline characteristics suggests that paramedic gestalt reasonably selected for opioid abuse or opioid-associated out-of-hospital cardiac arrest. Now, in the interest of transparency, next week we're going to talk about a paper from California that says that NarCAN actually does improve outcomes in cardiac arrest. So stick to that dial and you'll find out which one actually works. But Danny, we were talking about this off air. One of the interesting things between New Jersey and California is we have very different styles of EMS out there. So when we're looking at this study and it shows that, giving NarCAN in out-of-hospital cardiac arrest is not necessarily associated with improving outcomes, that's troublesome, right? Because as we talked before, we don't know what we're doing for cardiac arrest, but oftentimes I think we give NarCAN because, well, what else are we going to do? And in this study out of Camden, it just talks about that what just wasn't associated with improved survivability.
And this is the fun part about understanding science and reading literature and reading the journals, because it's very easy to cherry pick a study that you like and say, hey, this works and this is why it works, and look at this study. But you have to look at the totality of things, right? And what we find out is we're not really sure. And does that mean that the good work that everybody's done is for nothing? No. It just means that we need to look at it more. We need to understand this deeper. In this system, in this study, with the people that they collected for the study, NarCAN did not improve outcomes. But what I'm interested in is, what was the circumstances of the arrest? Was it a true witness arrest? Was it an unwitnessed arrest? What were the criteria that they were looking for? I think NarCAN may have a value. I think anything has a value if you can apply it. And this is where Gestalt comes in. And we talked about this. We even had an episode on Gestalt, which is wild. Definitely something that's, I tend to think when we have a lot of studies or we have studies coming out that are wildly different, I think it just means we haven't studied it long enough yet to get to a mean and a median where we know what works and what probably doesn't.
And something we've talked about previously, every study should kind of say we need more data, right? And this particular study, 769 patients, it is a good N. Like that's a good sample.
Sure.
And, the way that this study was done was, it's looking at how NarCAN, it was looking at NarCAN in cardiac arrest, not necessarily, differentiating the types of cardiac arrests. So, and this is where like kind of the nuance of studies gets really interesting, right? Were these patients that they were all run through the same kind of algorithm, the same protocol. Were there variables there? Was Gestalt a contributing factor to the study, right? We know that there's plenty of cardiac arrests that we go on scene, and this is a pronouncement, right, from the door. And, that patient may not be viable. Or how many patients could have used NarCAN physiologically and were missed, right? There's so many variables to it that I think a lot of people kind of fall through the cracks. But I think this is an interesting contribution in that cardiac arrest cocktail where we're not trying to give these medications arbitrarily. We want to give medications that will actually cause a difference and improve their outcome. Anecdotally, right? Or at least the way that I think in cardiac arrest, I don't know that there's a lot of harm to giving NarCAN empirically, right? Cardiac arrest, unconscious protocol, you give NarCAN because what the hell, maybe they overdosed, or maybe they, were overdosed. It's sometimes fun to imagine like a secret spy scenario where someone came in with like a needle, right? And like jumped in there and then no one saw it. And then we get to the patient, right? So it's tough without knowing what actually caused the cardiac arrest. So I don't know that operationally I have the problem really giving naloxone in these settings. Because I think a lot of times we talk about medications and it's like, well, if it doesn't work, we shouldn't give it. But this is one of those data points where it didn't work in this study, in this population. And we know, being in New Jersey has a very unique and interesting response model, right? To the point where the system that operates in Camden is different than the systems that you and I operate in day to day. So what I'm interested in, what parts of this, were there differences, I guess I should say, between the system in Southern New Jersey and the system in Northern California? Do the differences in those systems, how much of a contributing factor was that, right? In New Jersey, with a two-tiered system, it's possible that the first agency on scene didn't have NarCAN available to them, right? Now, whether or not they did is somewhat immaterial. That's not mentioned in this study, but I think those types of variables can kind of contribute to skewing the data a little bit. And that's kind of where my hesitation is. Next week, we're going to talk about a paper that had a sample of more than 8,000 people. But here, I do think 769 is good. So what do we think, Dan? In that type of setting where, we're close to hospitals when we're down in South Jersey, in the city settings, it's not like this isn't like, Gloucester County. There's 45 minutes from hospital to hospital. So do we think that this might have just been, NarCAN wasn't given, maybe it wasn't in the protocol, maybe there weren't enough arrests to go along with that? There has to be something, right? I have a lot of trouble believing that there's no positive outcomes from one cohort to another.
Well, it's definitely something to talk to the authors of the study about, and that just gave me an idea for a new episode.
Hey.
That being said, this is one data point. This is one point in time that they looked at, and it didn't work in this case. Does it not work for all cases? No, that's not what we're saying. Does it work in every case? No, that's not what we're saying. I think clinical gestalt matters. I think naloxone is probably a low risk intervention. I tend to go from the school of thought that no one's ever died from naloxone deficiency. They died from oxygen deficiency. I personally have never had a drop of naloxone in my body.
Shout out to Andrew Fisher for that one.
Yeah, we got to give Doc Fisher credit.
Yeah.
I've never had a drop of it in my body. Somehow I'm still alive. But in the space of a cardiac arrest is based on knowing that we don't know what we don't know. Right. Is it okay to just empirically throw this at somebody? And I think if you have a question or you're not sure, or you're reading that this could be a potential cause, it's not a downside. Does it improve outcomes? I'm not sure yet.
And I almost wonder, what was found on the initial assessment, right?
Right.
So, and again, how many patients were either included or excluded from the study just because of, pupillary findings? Where you go into an arrest, it would make sense physiologically the patient's pupils are dilated because they're in an arrest, so they're, they're vasodilated. How many people weren't given NarCAN because they didn't have, narrow pupils? So that's what I'm saying. I think there was a lot of patient populations that can be missed or overlooked.
Or they didn't fit the image of somebody with substance use disorder, so we're not going to give it. it's very tough to make that decision based on those kind of findings. What we really need is we need a large multi-center randomized control trial for cardiac arrest, giving NarCAN or giving placebo, and let's see what happens. Let's fight this out and see what.
And one of the things that's mentioned in the methods section here, because again, this wasn't entirely 24-hour coverage either. And again, getting back to the you've seen one system. It mentions bystanders and law enforcement officers could have also administered naloxone before EMS arrival with or without dispatcher assistance, which is great. The EMS guide cards sometimes call for naloxone use, but there is a high prevalence of opiate use disorder in Camden, generally, and in South Jersey, I would say probably writ large. So again, this is one of those studies where
I'd say across our state, I think I think opioid use disorder is a big issue in our state. But yeah. No,
and I think that's probably right. But again, this is when we talk about seeing one system. This was a snapshot in a very specific system over a very brief period of time, compared to, historical data. So this is something where it's a fun kind of thought experiment to have, right? Like, does more NarCAN improve outcomes? And that's not really what the data is showing right now. I do think it's interesting to see, all right, in this system, in this setting, this one group in New Jersey, there weren't a lot of, improved outcomes associated with giving naloxone. So what I hope is that other shops in our state try to replicate this data, right? When we talk about EMS data, there's so much that comes out of California and Washington and Texas and Florida. There's just not a lot that comes out of New Jersey. And we have enormous academic centers that border our state, both in Philadelphia and New York City, and we have major academic centers in our state. So I hope that this at least leads to something.
But Ed, that's a problem that's writ large across EMS. We don't research anything. We think we do, but in reality,
we tell ourselves we do.
And we need to do more research. And if this is just to say to anybody who's listening to this, because obviously you're interested in research and science, scientific literature. Go to your medical director. Go talk to your clinical people. Let's get some studies out there. It's not hard to do a paper. I did one. It was a lot of fun. I enjoyed it. It got published. It's a great thing for your resume. It's a great thing for your CV. You actually learn a lot about the subject you're studying when you do it. That's why they say to medical students and residents, that's why they want them to publish. That's why they want them to do research papers, because it does give them a broader knowledge of their subject. We can do the same thing, folks. We can do the same stuff. Go to your medical director. Go to your clinical people. Talk about this. Let's get some data out there so we actually know what's going on.
And I think one of the things that causes data to be so slow in coming out is that resistance to asking questions. There was someone else surely will be in charge of it. But one of the hardest things I think for providers to kind of wrap their head around is that we're just providers, right? And I think if you're involved in this process, if you want to know the answers that we don't see, Danny's right. You should ask your directors, talk to your staff, talk to your management, your staff, and see if you can get a group together. And then the power of an email in 2024 cannot be overstated. I mean, literally everything that you and I are doing here, Danny, is based off of emails that was just kind of sent from the dark. So there's a lot of information. There's a lot of data available. And so far we found in New Jersey, per this study, NarCAN is not effective at improving outcomes in out-of-hospital cardiac arrest. If that's been your experience, let us know. And if it hasn't been, let us know. We're going to talk about this paper from California next week. Come back next Monday for part 2 of this Monday Afternoon Journal Club from Ed Bowder and Dan Schwester and everyone here at the Overrun. Check us out on Spotify, YouTube, Apple Podcasts, everywhere that you get the stuff. Click the button, subscribe. You can find us on EMS1 and on YouTube and pretty much everywhere else you get your content. Be sure to check all that stuff out. And for the Overrun, we will see you next Monday.